Thanks for the thank you for the introduction, Chris.
Oh, you're very welcome.
Yes, and I'm happy to be able to talk about an exciting treatment that I've enjoyed offering to my patients for a number of years now. So with I'm trying to move my slide forward. Let me see. For some reason, I can't. So give me one moment, please. I don't know why I cannot move it. So Chris, give me one moment here. Move a slide forward. So sorry. Let me get this. Oh, here we go. Okay, so sorry about that. All right, so good evening, everybody, and thank you for making time to listen to and to see a presentation on the treatments for bladder and bowel incontinence. So as Chris said, I'm a urogynecologist. I did most of my training here in Colorado. I'm in private practice in Parker, Colorado, but I see patients from the whole Rocky Mountain region, which has been, I think, with having such a subspecialty, patients are referred to me from throughout the state, and my office is very capable of helping patients accommodate their travels if they're traveling from afar. The issue with incontinence, whether it's having good bladder or bowel control, it's the embarrassment of the problem that keeps people from even asking physicians or their own physicians if there's a solution to it. I just saw a patient today who has suffered from bowel control problems for over 20 years. And she mentioned that my practice was the first one that ever asked her about the problem as part of a questionnaire that we have. So it allows, I think, by asking the questions and creating an environment where patients are comfortable talking about the problem, they can finally get help. So it's the embarrassment of the problem that 44% of people are so embarrassed that they never bring it up, whether even to a close friend or a physician. But part of my excitement about tonight is trying to change the embarrassment or the taboo and just create a comfortable experience for patients to be able to get some help. And so, and with that, the idea is to be able to live your life with a better quality. So it's really, it's not a life-threatening problem, whether it's not being able to control your bowel or your bladder, but it's improving your quality of life. So for today and for tonight, it's just, I think if we all understand what the issues are with bladder control, what the causes are, what the treatment options are, and then we can talk a little bit more about some exciting treatments that are available to us. So I think understanding that you're certainly not alone. If you never bring it up to a friend or a family member or a physician, you feel you're suffering in isolation. But the reality is, as this slide shows, 1 in 6 adults have an overactive bladder. So that means they're having poor sleeping patterns, they're losing confidence, their self-esteem is decreased. So that leads to isolation, and it affects people's intimacy. There's many negative effects that leads to. So if you think of, as a urogynecologist, I've been treating urinary incontinence for over 20 years. And this statistic always surprises me, that there's more adults in the US that suffer from incontinence than there is people with diabetes. And you hear diabetes all the time. People talk about it openly and comfortably, but I think the late, the delay in getting treatment is very prevalent with incontinence, partly because it's not life-threatening. So it is certainly not normal. So I have many patients will come to see me, and I ask them, well, why did you not seek help? Aside from being embarrassed to bring it up, is there's also this misperception that that it's normal, So perhaps if a woman has had 2 or 3 babies, they think, well, it's normal to leak urine. I've had babies, but that's not true. I've seen many patients who've had 5, 6 children, and they don't leak any urine. So that's certainly not normal or acceptable, I think, to tolerate incontinence. And so what is abnormal? It would be going to the bathroom more than 8 times a day. That strong, urgent feeling, you have to go now, that's not normal. And then people will find themselves plan their activities based on where the bathrooms are, or they'll just not leave the home as often, or they'll avoid social interactions, they'll avoid exercise. It's associated with patients having a higher incidence of depression. And if you think of the effects on, so in order to lead a more comfortable life, maybe they're wearing pads, and that can become very expensive as well. So all these things that you see on there is an indication that there's something wrong with your bladder, and to certainly seek help. So the bladder and how the bladder works, you think of as the bladder fills with urine. When it's about half full, it should send signals to your brain to give you the urge to go to the bathroom, and that should give you enough time to go to the bathroom comfortably, and without leaking. And so with incontinence, I always tell patients, it's like we're all born incontinent as infants, and it takes a couple of years for the nervous system to mature enough for us as children to know how to control and not wear a diaper anymore, or have the ability to go to the restroom and empty on your own. But and there's many factors in life, whether it's childbirth, injuries, other things that can lead to an imbalance of that nervous system. And so as we age, we kind of go backwards. As we age, our nervous system may not remain may not be working as well, where the ability to control bladder is diminished. And it's kind of the same idea with bowel control. So they may not be as prevalent as urinary incontinence, but the impact on the quality of life of losing stool or soiling, that's much more significant than urine loss. Although they're both, I feel, also unacceptable. So the understanding that achieving good bowel or maintaining good bowel and bladder control has to do with a good and intact and working nervous system. And that's where the therapies that we're going to talk about tonight come in, and they fall in as a way of a good treatment option. So in understanding the different causes of incontinence, perhaps simply if people are drinking too much water or too many fluids, that may lead to more urinary frequency. There are certain medications that can lead to more urine production and trouble controlling the bladder. But then if you look down at the 4th bullet point, there's pregnancy, childbirth. This is probably the most prevalent the condition that will contribute to bowel and bladder control issues. Radiation, pelvic floor surgery, other things that can cause any pelvic floor trauma will create a difficult situation and be able to control your bladder. So looking for bladder control problems, kind of 3 categories. There's stress incontinence, which is probably the most common that occurs following, let's say, a vaginal delivery, where leakage with coughing, sneezing. That's the stress incontinence has to do with urine loss associated with activity. Even young, physically active women before childbirth will also experience stress incontinence. So it can happen even in that population. Then urinary retention is the inability to empty your bladder fully. And that may lead to having a frequent need to go to the bathroom because your bladder is never empty. or leakage of urine due to, it's called overflow incontinence. And then the overactive bladder, which is also very prevalent, the urinary urgency, frequency, urge incontinence. So those are the three categories. So as I take a history in a patient, I try to figure out, well, in which one of these three groups is that patient in, and because it's a different treatment that I can offer depending on where they fall. So with the stress incontinence, it's, as I said, it's the leakage with sneezing, coughing, laughing, exercise, lifting something heavy. It's funny with the recent COVID that we've had, we've seen a lot of patients come in because of the chronic coughing that they've had. They end up really being affected by the incontinence. So that would be the stress incontinence that occurs with a cough. The urinary retention is where the bladder isn't fully emptying. So that the leakage that occurs there is a little bit more like dribbling, more overflow incontinence. It's like if you walk really quickly with a full glass of milk, that milk's going to spill. And that's the kind of the spill or the loss that you have with that happens with urinary retention. But patients with retention, maybe their presenting symptom will be mainly frequency. They're going to the bathroom all the time because their bladder is always full. And then some of the treatments for frequency, let's say medications, will make retention worse. So it's important to figure out what is the diagnosis before we begin a treatment. And then the overactive bladder. So there could be the urge incontinence, which we would call the overactive bladder wet, where there's leakage. And so obviously those patients will be using pads, diapers even. They restrict the amount of fluids they drink. And then what's an often complaint is, let's say I have leakage if I'm doing the dishes, or if I drive into my garage and then I have to run to the bathroom. That's more overactive bladder. That's urge incontinence. Or there are patients who have a lot of urgency and frequency without leakage. Patients that are going to the bathroom every hour, but they maybe never need a pad. They just are able to hold their urine, but they're getting up at night all the time, and they're going very frequently during the day. So that's a different patient than one who has incontinence, but still is very troubled by their bladder. And then also the fecal incontinence. So now there's bowel control issues. These patients will have a lot of urgency, like an urgent need to find a bathroom. They may make it there most of the time. But if they have days where the stools are soft, or if their bowels are watery, they're going to have accidents. And then they end up staining. So they'll come in, maybe it all depends on how you ask the question, right? So they may not be losing formed stool, but they're going to be soiling and urgently going to the bathroom. And that is the quality of life, the impact on quality of life is tremendous when the bowel control is a problem. And so now, so the good news, there's treatments. There are several treatments for overactive bladder. And the important part is the first step is getting a diagnosis, as I mentioned. So if urine loss, there's three different types of bladder control issues. So it's understanding which is the what is the diagnosis, getting a correct diagnosis. And then there's lifestyle changes. So if some patients come in and they're drinking way too much water, and if they have a small capacity bladder, they should maybe not drink as much, or they're going to be always going to the bathroom. There's medications, and where the medications come into play is kind of allowing the bladder to hold more urine, buying them time to get to the bathroom. And then there's the advanced therapies, which we're talking about tonight. So the lifestyle changes would be obviously is avoiding fluids or drinks that will irritate your bladder, avoiding too much, avoiding, not drinking a ton of water, exercises, biofeedback, Kegels. So the therapies here would be being careful with what you're drinking, but also maybe seeing a physical therapist for improving your pelvic floor, behavioral management, biofeedback. All those things are helpful. And always actually the first line therapy. It's when, if that doesn't work, then combining it with medications. The problem with medications, as I said earlier, one example would be if they have urinary retention, you're going to make that problem worse by taking medications that relax the bladder. You have to take it daily. And unfortunately, a lot of the medications have a lot of bad side effects that makes it impossible for patients to continue being compliant. And there's the 72% of patients who are prescribed medications stop taking it after 6 months. So what I see a lot is many patients that come to see me have seen other urologists, urogynecologists, and they're maybe their primary care doctors, and they've tried many types of treatments in the past, and they end up not continuing with the medication, so they don't really get proper therapy. And then another form of treating overactive bladder would be with Botox. That is an in-office procedure that will have to be repeated 2 to 3 times a year. And unfortunately, 51% of patients will stop after 2 treatments, whether because of the needing to go get a procedure done. It can be uncomfortable for some patients and painful. And then the side effects is that the way the Botox works is to relax the muscles of the bladder, so that the bladder doesn't have an accident, that doesn't have a spontaneous contraction that leads to accidents. The problem with the Botox, though, is it may relax the bladder so much that you end up having retention. So again, that's another option available out there. And I see many patients who've tried it, and just like that, it says, as what it says is they've tried Botox, but they don't continue with it. And then there's advanced therapies for both bladder and bowel. So that's where the sacral nerve stimulation comes in for patients who have tried several other therapies and have not had success, or are wanting better treatment, is the InterStim. Now, there could be sacral nerve stimulation, which is what InterStim is, or there could be tibial nerve stimulation, which is the Medtronic neural system. So now for bowels, you're a little bit more limited. There's no first line treatment for bowel control would be trying to have better bowel habits. So avoiding loose stools, trying to not allow yourself to. You have to be very careful with what you eat. Keep your stools a little bit on the firmer side, harder side, and then aside from dietary modification, then there's InterStim. We used to do surgery where we would reattach the sphincter. That would be very painful. The success rate wasn't that great. Now, first line therapy has become the InterStim for bowel control. And then just for, this is a good picture showing how there is a needle that goes through the skin. It's like an acupuncture size needle next to the tibial nerve. And then the electrical stimulation is the patients have to come in every week for 3 months for 30-minute treatments. So in my practice, when my patients travel from very far away, this is not a very practical option. Patients who live close and nearby, then they may consider this. But it's a treatment that you have to continue to go to the office. So it's 30-minute treatments for 12 weeks and then monthly maintenance. So it becomes a little prohibitive for some patients. And then the InterStim. So this offers gentle nerve stimulation to the sacral nerves. We've talked about bladder and bowel control. Many of my patients have both. So they have an overlap. They have both urinary control issues and bowel control issues. And this one therapy helps with both problems. So Botox helps just for the bladder, medications for the bladder doesn't help with the bowel issues. So this is a wonderful therapy, because if you think of the issues with bladder and bowel control is all related to the nerves. And so if we can provide constant stimulation of the nerve for it to communicate better with the pelvic floor, then both issues are helped. Now, in this slide, you see a larger, this is a battery. So it's a generator that gets inserted underneath the skin in the upper buttock. This one is Intersim X that will, the battery will last 10 to 15 years without having to charge it again. So 10, 15 years later, once the therapy isn't, well, once you notice that the battery has died, then you simply replace the battery. The smaller one is Intersim Micro, and that is a rechargeable battery. That is also an option that patients have to choose. So it's good to have both options, and patients can choose what is more comfortable for them. And then, so as I evaluate patients and if they have failed multiple treatments, they have both urge incontinence and maybe bowel incontinence, and I'm thinking of Interstim as being a good option for them. We have to first prove that it'll help them. And so the beauty is that there's a very simple test that we can do either in a doctor's office or in a surgical center, where we place very small thin wires next to the sacral nerve done under local anesthesia. And the patients get to test out the stimulation for 7 to 10 days, let's say, to see how it improves their bowel and bladder control. During that week of testing, if they realize that they have much better control, or they can empty better and their quality of life has improved, they pretty much test drive it to see how life would be if the nerves were working better. And then the next step would be a very minimally invasive surgery to implant the lead and the battery. And so it's through that test that one determines whether it's the right treatment for you. And so it's the patients with symptoms that are of overactive bladder, retention, and fecal incontinence. If they notice a marked improvement, then they move on towards the next step, which is the implant. So think of it as more of a pacemaker. And so the therapy is safe and effective. 84% satisfaction among patients who use it. So, and if you think about it, this is a 3-time greater improvement in the quality of life compared to medications. And that's probably the most important point here is we can improve bladder control with overactive bladder medications, but the quality of life that is achieved is far greater when they're not relying on medications, and one doesn't have to think about their bladder as much anymore. It's just the nerves are stimulated so that they can have better control. And then 76% of patients achieve success, meaning that they have a greater than 50% reduction of their symptoms. So for example, patients who are getting up 4 or 5 times at night, with Interstim, if they get up only once at night, that's a marked improvement, that they're able to rest better, sleep better, and have a better quality of life. So if a patient is needing to change their pads 2 to 3 times a day, and now maybe just wear a light pad for the therapy, that's success. That's a marked improvement. And that's when one does the test, that's a simple outpatient test before doing the implantation. One can see how life would be so before moving forward. So it's all about, getting back to a better quality of life and not being controlled by your bladder or your bowel control issues. And so here we open it up to questions. Chris, our moderator, will I'm happy to answer any questions with regards to the therapy or symptoms. And as Chris said, your questions are put out and it's confidential. So I'm happy to help out here.
Okay, Dr. Aguirre, that was a fantastic overview of all the different treatment options for overactive bladder and bowel incontinence. We had several questions that came through, and I'll read those off. And if you could provide a few answers and a little color to those,
Okay.
I think that would help clarify some of the things we talked about earlier. The first question that came in was, how long does the InterStim last?
Oh, sure. So good question. So I've been putting InterStim in now, my gosh, for 22 years. And the battery that we've had for most of the time, for a lot of that time, the battery would last anywhere from 4 to 6 years. And now earlier this year, a battery has been improved where it can last 10 to 15 years. So the battery itself can last, as I said, up to 10 to 15 years, but it's if the battery it's like any battery may lose its energy, 10 to 15 years later, patients will start experiencing symptoms again. And then it's a simple 20-minute procedure where we replace the battery. So the goal is for patients to receive therapy 24 hours a day, 7 days a week, without being controlled by their symptoms.
Perfect. The second question that came in, which is always on people's mind, is, can I have an MRI if I need one with this device implanted?
Yes. So again, with the improved technology, now these are MRI safe. There's no need to remove the system in order to get an MRI. And that's a very important quality, because as people age, MRIs may be required or ordered by physicians. So the patients would be provided a card letting their physicians know that it's MRI compatible and safe.
Next question. Will my insurance cover it?
Yes. So we would. So my office would make sure that your insurance we would get pre-authorization for it. It's now most of the insurances that we see and that we are in contract with are what they're looking for is that patients aren't jumping to this as their first line of therapy. So by the time they come see me, and if patients have had symptoms for many, many years and they've failed medications, they've failed physical therapy, as long as they meet the criteria that they've tried other therapies that have not worked to the patient's satisfaction, then we request a pre-authorization before we proceed.
All right, perfect. The next one relates to the actual implant. And the question is, can you see the InterStim device when it's implanted, and will it protrude?
Yeah, so there you can see the incisions through which they were placed, but no one knows that you have a device in, so and after 4 to 6 weeks of healing, the tenderness around the area where it's implanted goes away, and then it's painless. So you're really not bothered by it, and no one knows you have it. So it is something that's hidden nicely.
The last question is, you mentioned that there is a test to see if you're a candidate. Is the test done right in your office? And do you use anesthesia for this test?
Yeah, so the test can be done in the office or in a surgical center under local anesthesia. So patients will just drive themselves. It's like having a very brief procedure that you'd be in the office for about an hour. We use local anesthesia to numb the skin, and the testing goes smoothly. So it's certainly doable without the need of any medications or anesthesia.
And then regarding the test, if you have a test done, how long will it take to know if it will be helpful?
Yeah, so I mentioned earlier, so the test will last about a week, and the slide showed that that we can do the test between 3 and 14 days. So if patients who have fecal incontinence or urge incontinence, they will know pretty quickly that the system is working. So usually by the day 3 or 4, they're already, so we have them track a diary, a bladder and bowel diary, to demonstrate both to yourself, to me as a surgeon, and also your insurance company that your symptoms are markedly reduced and improved. So what we're looking for is the reduction of symptoms by more than 50%. And we can often get to that by the 3rd or 4th day. Now, patients with urinary retention require a little longer to notice the benefit. And that's why sometimes the test will last 7 to 10 days in those patients. And it's all determined by the bladder diary. And usually patients know, but by the time they come back the following week, some of them don't want to have those test wires removed because they've maybe had the best several nights sleep they've had in years. And so the way our office coordinates with the patients and the schedule is, if we pretty much, if about 80% of patients who do the test come back knowing that this is their therapy, and that they have great benefits. So we move forward with the placement of the pacemaker within 2, 3, 4 weeks from that date. So it's the patients know that they know right away that it works for them.
Just a couple more questions. When the patients are doing the test or have the implant, do they feel stimulation?
Yeah, so the location that we place it in, what patients feel is that they'll feel a kind of flutter or a tapping sensation in the bicycle seat area. And once that's what tells me that I'm next to the correct nerve. And then that flutter goes away. It's like we may be wearing jewelry, but we don't feel the jewelry after we put it on for a little while later. So your body gets used to that sensation. And so it's providing therapy without you even being aware of the stimulation. That's a great question, because you'd go crazy if you feel a tapping sensation 24 hours a day, 7 days a week. So it works without you even being aware of it.
All right, then last question was, what kind of an impact does this usually have on your patients' lives? Is this a major change for them?
Right. I think it's huge. So it's, by the time, the patients who are a candidate for this therapy, they've suffered for years, and they're very bothered by their symptoms. And for such a simple, minimally invasive procedure to provide them much better bladder and bowel control, their quality of life is impacted greatly, because they're also not having the side effects of medications or the ongoing costs of medications and pads. They're in their body. Their life is much improved.
Well, Dr. Aguirre, that wraps up the questions. And do you have anything you'd like to add?
Yeah. So for patients who can identify with some of the symptoms that we talked about in these conditions, if you have our phone numbers listed right there on the screen, or you can email us or contact us through our website. And if you mention this Zoom webinar that you participated in tonight, then my office will certainly bring you towards the top front of the list for an appointment. Try to work you in as best as we can, and I'd be happy to take care of you.
All right. Well, I can close it out, and just thank you to everyone for joining us tonight. Immediately following this webinar, a survey will appear. If you wouldn't mind taking a few moments to fill out the survey. And then just to reiterate, as Dr. Aguirre said, if you call the office, the staff knows that there's some participants that may call here in the near future, and they'll do their best to expedite the appointment process.
Well, thank you, Chris, and thank you everyone for attending.
Have a wonderful night.
Okay, bye.